For the second speaker, we are going to listen to Dr. Aliaa Elaghoury, the president of Alexandria Thyroid Association. She is going to talk about a very interesting topic, fasting Ramadan in patients with adrenal insufficiency. This is a topic that we don't hear about very much, maybe first because it is, thank God, a rare disease, and second because maybe we don't have so much data about fasting Ramadan with adrenal insufficiency. So listening to the presentation today, we are going to hear about, in the first place, can patients with adrenal insufficiency fast during Ramadan? And if they are going to do this, what is the preferred agent? Is it hydrocortisone or prednisolone? And if they are going to fast, what is the best regimen or the best timing to prescribe glucocorticoids during Ramadan? And above all, what are the fast rules for these patients? So we are going to hear all this from Dr. Aliaa Elaghoury. Go ahead, Dr. Aliaa.
Thank you, dear Tamer. As my dear colleague Tamer said, my topics is about fasting Ramadan with adrenal insufficiency. At the first, during the months of Ramadan, the majority of Muslims globally observe the religious obligation of fasting from dawn till sunset for 29 or 30 consecutive days. As the timing of Ramadan is based on the lunar
Dr.
calendar, yes.
The screen is not shared.
Screen is not shared. Why? Okay, sorry. Okay, now yeah, Tamer,
yes,
shared?
Yes.
Okay, sorry for that. Okay. So during the Ramadan, as the timing of Ramadan is based on the lunar calendar, Ramadan falls 11 days earlier annually, with consequently short fast in the winter and longer fast in the summer months. During fasting, during the long days of Ramadan, we may have a long hour to fast up to 20 hours in temperature area. To be remembered that taking medicines orally or intranasally is considered breaking the fast. At its core, Islamic law, the Sharia, aims to protect integral value, including an individual life, well-being and health. Islamic rulings make several exceptions to lift the obligation for fasting for those in whom it may entail hardship, such as the elderly people, those who are traveling, those with significant mental health, and the pregnant woman, if there is known or potential risk or an occurrence to the health of the mother and or the fetus. Islam also supports those with appropriate ailment to terminate the fast or be exempt from fasting if there is a reasonable expectation that a person will become ill. In such a circumstance, we have two alternative options in spite of fasting. Either making up the missed fast when their health permits them to do so, either when the illness is no longer present, such as in acute illness, or when the illness is not worsened by fasting at another point in time in relation to the chronic illness. For example, fasting in the winter when the days are shorter. The other option is the fidya. The fidya in those whose illness will not permit them to keep fast indefinitely, this being replaced the fasting. As our Quran said, أياما معدودات فمن كان منكم مريضا أو على سفر فعدة من أيام أخر وعلى الذين يطيقونه فدية طعام مسكين فمن تطوع خيرا فهو خيرا له وإن تصوموا خير لكم إن كنتم تعلمون. Also, appropriate ailments can also include a condition which is stable, but through fasting, the condition can adversely affect the health or increase the risk of doing so, especially with abstaining from the use of water and medication. Example, steroid replacement in patient with adrenal failure. Therefore, patients with adrenal insufficiency who partake in fasting may be at risk of dehydration or an adrenal crisis. For adrenal insufficiency, reasonable expectation of illness or compromise would be determined by applying one of the three following criteria: prior experience of what fasting does to the ailment, or the common knowledge, example, effect on a person with Addison disease who does not take their latter doses of hydrocortisone tablets, or the opinion of a qualified physician on this matter. As you all know, that adrenal insufficiency can result from either primary adrenal disease, including Addisonian disease, or secondary and adrenal insufficiency due to problem in the anterior pituitary gland, or tertiary, being the patient on a suppressive doses of exogenous steroids for another condition, or the problem is in the hypothalamus. The adrenal cortisol secretion has a circadian rhythm with a peak level at around the dawn, as you see here, and levels that declines during the days with the low level at night when asleep. Depending on the type of adrenal insufficiency, different approaches in management may be needed. However, all patients with adrenal insufficiency need glucocorticoid replacement to try to mimic the natural circadian rhythm of cortisol secretion. Religious fasting could be at odds. The multiple dosing mandated with the standard treatment regimen associated with hydrocortisone replacement. It's one. Furthermore, the changes in the daily routine and behavior with some individuals staying up late into the nights, these may alter the cortisol rhythm and therefore dosing and timing requiring during these months. Predicting how to manage this patient is important, as unnecessary excessive steroid doses may be harmful, and inadequate steroid cover may result in an adrenal crisis. Risk of the adrenal crisis may be even higher in primary adrenal insufficiency with mineralocorticoid deficiency, or secondary adrenal insufficiency with concomitant pituitary diabetes insipidus, as compared to the tertiary one, due to the greater risk of electrolyte imbalance and the hypovolemia. Fasting with adrenal insufficiency can result in a complication, especially if the patient understanding of their health condition is low. Therefore, patients on long-term glucocorticoid replacement wishing to fast need a thorough clinical assessment, ideally some months before Ramadan. First, the standard glucocorticoid replacement regimen. As you all know, our patient may be on either hydrocortisone, which owing to its short half-life needs to be taken twice or thrice a day, or prednisolone, which has a longer half-life and can be taken once daily on waking, or cortisone acetate, which is taken twice daily, and lastly, the modified release preparation of hydrocortisone, which are typically taken once a day. Additionally, patients with secondary adrenal insufficiency may be on other pituitary hormone replacement, including thyroxine, growth hormone, sex steroids, and desmopressin. Those with primary adrenal insufficiency may also be on fludrocortisone. The typical replacement doses of hydrocortisone is from 15 to 25 milligrams, taken at a higher doses in the morning, noon, and lower doses in the early evening, while prednisolone is used at a doses of 3 to 5 milligrams in most patients in the morning. And now Ramadan-specific steroid regimen. Although twice daily hydrocortisone is a potential option, and the doses will need to be administered at dawn and sunset, But if the day is long, cortisol levels are likely to fall significantly before sunset. And so patients on this regimen need to be advised to terminate their fast if they become unwell before sunset. There is no available evidence to suggest that the stress of fasting warrants a dose increment in steroids. However, this is something that should be individualized. Also, stress from partaking in activities such as Tarawih, which last approximately from 1.5 hour to 2 hours, may need additional consideration. Regarding the modified release hydrocortisone preparation, there are currently very rarely prescribed in some countries like UK, but whilst patients taking these forms can theoretically fast without any dose adjustment, their very high cost, poor availability worldwide, and their no use experiences don't make them a suitable option as a first-line recommendation for Ramadan-specific steroid dosing. So the easier alternative is the once-daily prednisolone. The single tablet of prednisolone 5 mg has the advantage of being widely available throughout the world, as it is the only glucocorticoid available in many countries. It also offers a theoretical advantage in temperature countries which are further from the equator, where the current duration of fast is longer. Prednisolone has a longer half-life than hydrocortisone, so the dose equivalent is not linear. The dose equivalent ratio for hydrocortisone is between 6:1 and 8:1. A full replacement dose of prednisolone is between 2.5 and 5 mg once daily. Mineralocorticoid replacement should be continued at the same dose. Fludrocortisone is usually taken as 50 to 100 microgram once daily. However, doses may be higher in some individuals. Synthetic glucocorticoids such as prednisolone have a lower mineralocorticoid activities as compared to hydrocortisone. Given the relatively modest contribution toward mineralocorticoid replacement, hydrocortisone to prednisolone conversion don't usually need additional fludrocortisone doses. Most patients with primary adrenal insufficiency should therefore take 5 mg prednisolone at their usual morning dose fludrocortisone at dawn during suhoor if they choose to partake in fasting. Conversion from hydrocortisone to prednisolone can occur immediately before the months of Ramadan start. Patients with secondary adrenal insufficiency should preferably have all their replacement hormone, including the choice of steroid, optimized prior to Ramadan. Patients who are on higher doses of steroid for other conditions should consult their specialist about whether fasting is safe and should continue the steroid treatment at the same dose if over an equivalence of prednisolone 5 mg. Regarding pregnant and breastfeeding women, if we're insisting on fasting, they could be managed with once daily prednisolone from 3 to 5 mg, depending upon the stage of pregnancy. During lactation, this results in negligible amount of prednisolone in breast milk and is unlikely to cause any systemic effect in the infant. And now, this is the practical guidance for the healthcare practitioners when approaching this situation in their clinic. Whilst all patients with adrenal insufficiency have a high probability of complication during prolonged fasting than the general population, it may be useful for the clinician to risk stratify patients when discussing the implication of fasting on their patient health. This risk stratification should take into consideration not only the patient endocrine condition, but also their other comorbidities, medications, and overall frailty. Patients as well as clinicians may find this approach beneficial when making informed decisions about fasting during Ramadan. Such an example of risk stratification has been utilized In authoritative international diabetes guidance, the International Diabetes Federation endorsed diabetes and Ramadan Bidar guidelines and has been approved by the Islamic Organization for Medical Science and the International Islamic Fiqh Academy. The risk stratification for fasting with adrenal insufficiency include: if the patient have stable and well-controlled adrenal insufficiency, he is considered low risk. If has no significant comorbidities, is considered of low risk. And if treated concomitant mineralocorticoid deficiency, he is considered moderate risk. In both low and moderate risk, decision to not fast based on the discretion of medical opinion and the ability of the individual to tolerate fast. On the other hand, the high-risk patient should be advised not to fast, and this include the recent diagnosis of steroid dependency within the last 3 months and the pregnant lady. The very high-risk groups must be advised not to fast, and this include the multiple morbidity patients, the major organ system involvement, and the concomitant diabetes mellitus on insulin treatment, the concomitant pituitary diabetes insipidus, the adrenal crisis in the last 12 months, the untreated concomitant mineralocorticoid deficiency, and the untreated TSH deficiency. Patients in the low and moderate risk categories, as I said, could be supported through religious fasting with appropriate education and counseling, while those in the high risk and very high risk category should be encouraged and supported to explore alternative options to fasting. In the context of the current COVID-19 global pandemic, it is better to upgrade the patient baseline categorization to the next categorization. For example, the moderate risk become a high risk. Emergency management plans. All patients with adrenal insufficiency wishing to fast should receive up-to-date education on steroid sick day rules, verbal and written, and must have a valid intramuscular hydrocortisone pack with training on how to administer these prior to the commencement of Ramadan. Patients should be warned of the symptoms of acute adrenal insufficiency and should be advised to urgently terminate the fast and administer intramuscular hydrocortisone if they develop these symptoms. As you see, this is the steroid emergency card, and all patients should have this steroid emergency card with the local endocrine unit or the local treating doctor where they can go. Patients with concurrent mineralocorticoid deficiency should advise to avoid prolonged sun exposure to minimize salt and water losses. Adult patients with adrenal crisis need to be managed urgently in the hospital with intravenous fluid. Patients should not delay hospital admission for fear of contracting of COVID-19. This is very important. Any situation that requires doubling of the glucocorticoid doses or emergency hydrocortisone injection warrants immediate breaking of the fast and abstinence from fasting until complete recovery. Regarding the hydration advice, it is extremely important that all patients ensure adequate hydration with non-caffeine containing fluid between the iftar and suhoor. Given the presence of concomitant mineralocorticoid deficiency, patients with primary adrenal insufficiency should be advised to rehydrate with electrolyte imbalance, with electrolyte replacement, fluid with added salt, whilst those with secondary adrenal impairment with pituitary diabetes insipidus are likely to require more free water. The sick day rules for the adrenal insufficiency in Ramadan includes: regarding the mild intercurrent illness, no further action needed. Only the patient should be encouraged to have a good hydration between iftar and suhoor. Regarding the moderate intercurrent illness, patient should break the fast immediately and abstain from fasting. He should double the usual daily glucocorticoid dose, rehydrate by drinking plenty of fluids, and always carry the steroid warning card. Ensure you have that the patient have a valid steroid injection pack that he can use, or his carer or cohabitant can use this pack when the patient is in emergency condition. Resume the fasting only when the patient is completely well, and if he is ensured that seeks medical advice or his consultant before resuming his fasting. Regarding the severe intercurrent illness, or if the patient have a persistent vomiting, he should break his fast immediately and abstain from fasting. Should to be given an emergency hydrocortisone intramuscular injection. Seek the urgent medical attention immediately as emergency management in hospital with intravenous fluid and hydrocortisone, and resume his fasting only when he is completely well. The patient on exogenous glucocorticoid for other condition should consult their specialist regarding the safety of fasting. In most scenarios where someone is well enough to undertake fasting and is on exogenous glucocorticoid, the long-acting formulation such as prednisolone are used. For patients who are on tapering doses of prednisolone for other conditions with no underlying adrenal insufficiency, there is no evidence that a change in the dose is required during fasting. Patients should be continued during fasting at the same dose, and the further dose reduction should be discussed with their physician and may be delayed until Ramadan is over. And now we have some cases scenario to give you some information if you have a similar like cases. Our first patient is a patient need to fast with ACTH deficiency. Mrs. Aida is a 45-year-old lady with partial ACTH deficiency following transsphenoidal surgery and external beam radiotherapy for acromegaly. She takes hydrocortisone once a day on waking for many years. She would like to fast during Ramadan and has in fact been doing this for the last few years. She reports taking hydrocortisone at suhoor. She was able to fast but find herself feeling very well in energy by iftar time. She has struggled to take part in Taraweeh after breaking her fast. This patient, could we advise this lady to fast? Can we help this lady to partake in Taraweeh? Yes, we can, either by an additional evening dose of hydrocortisone. She can take the 5 milligram, particularly if she wishes to partake in evening prayer. Or as an alternative, she can temporarily be switched to prednisolone, 5 milligram at dawn, to can partake in prayer. This patient Mr. Muhammad is a 60-year-old gentleman with long history of primary adrenal insufficiency due to Addison disease, for which he takes hydrocortisone 10 milligram on waking, 10 milligram on midday, and 5 milligram at 5 p.m. And fludrocortisone 100 milligram on waking and 50 on the evening. Although he has been discouraged from fasting in the past, he would like to attempt fasting during Ramadan this year and would like to discuss this. Can we advise this patient to fast? Patients with primary adrenal insufficiency are likely to be at a high risk of adrenal crisis due to the higher risk of dehydration and hypovolemia from concomitant mineralocorticoid deficiency. So for Mr. Muhammad, he has the alternative to fasting during the winter, shorter months is an option. Or if the patient still chooses to fast during Ramadan, non-consecutive fasts and trial fasts should be encouraged. Hydrocortisone should be switched to once daily steroid replacement, prednisolone 5 milligram at suhoor, and he should be advised to take all of his fludrocortisone at this time, as fludrocortisone has a long half-life and splitting the dose have no advantage. Importance of hydration should be reinforced for Mr. Muhammad, considering the fluids and the electrolyte replacement. And now for this lady, Mr. Khadija, she has a multiple morbidity with adrenal insufficiency. She is 75 years old lady with congestive heart failure, requiring daily diuretics, type 2 diabetes on multiple daily insulin injection, and secondary adrenal insufficiency on replacement doses of hydrocortisone. She wants to fast Ramadan, but afraid from life-threatening adrenal crisis, fluid overload, and electrolyte disturbance throughout delaying and or omitting her medication to partake in fasting during Ramadan. Did you advise this patient to fast? This patient is in the high risk category. This patient should be actively discouraged from fasting, and giving the potential adverse effect on her health, this patient should be advised to pay fidya as an alternative to fasting. As regarding patients with panhypothyroidism and secondary adrenal insufficiency, we have Ms. Zainab, a 26-year-old lady with ACTH and TSH and gonadotropin deficiency. She is currently well managed on hydrocortisone 10 milligram on waking, 5 milligram at the midday, and 5 milligram at 5 p.m. Levothyroxine 75 microgram once daily, and combined hormone replacement therapy. She would like to resume fasting, which she is underlooked prior to her problem. What is your decision regarding fasting for this patient? As this patient is well managed, she is a low-risk patient. Once daily steroid dosing with prednisolone should be considered to give adequate steroid coverage through the day. Fasting with well-controlled hypothyroidism is safe, and we will hear a very excellent lecture, inshallah, from my dear colleague Tam. Regarding the oral hormone replacement therapy, she can continue on combined hormone replacement therapy as an option if she would prefer to avoid menstrual bleeds during the months of Ramadan, and then revert to the sequential combined option after Ramadan. Our last patient is a patient fasting with panhypopituitarism, including the diabetes insipidus. Mr. Sameh is a 55-year-old gentleman with panhypopituitarism secondary to a pituitary adenoma, managed with 10 milligram of hydrocortisone on waking and 5 milligram on lunchtime, levothyroxine 100 microgram, and desmopressin 60 microgram twice a day. He expressed a desire to fast during the months of Ramadan. He asked about the participation or the practicality of doing this. Can this patient fast? Given Mr. Sameh has pituitary diabetes insipidus and with cortisol, thyroid, and gonadotropin deficiency, he is in the high risk category. He has risk of severe dehydration, electrolyte imbalance, with the risk of adrenal crisis. In spite that patients on Mr. Sameh on anterior hormone deficiency can be managed, given the prolonged fast and the disruption in regulating fluids and the electrolyte homeostasis in pituitary diabetes insipidus, there is no safe management for these patients should be considered. Thus, fasting should be strongly discouraged on health ground. Furthermore, the intake of desmopressin, either orally or intranasally, is not permissible during the fast. Thus, an alternative to fasting, the Ilfidia, is advised for these patients. In patients with mild pituitary diabetes insipidus, on once daily desmopressin who insists on partaking in Ramadan, he can fast if the fasts are less than 12 hours in duration, but he should first undergo supervised trial fast with close fluid balance and electrolyte monitoring prior to the commencement of Ramadan. So my conclusion for all these patients with adrenal insufficiency who wish to fast during Ramadan, there is a strong need for patient and treating endocrinologists and the religious community figurehead زي الإمام to engage with each other and discuss the contemporary of medical issue, as this patient can fast or not. So if you are confronted with a patient with adrenal insufficiency, he need to fast. If the patient need to fast, we should put our risk stratification for this patient. If he is very high risk or high risk, we explore the alternative for this patient. If he low risk, he can fast. If he refuse and is still choosing to fast, the education and optimization and the emergent plan, as I mentioned, should be applied. And thank you and wishing you a safe Ramadan.